started actually beginning of September or late August. What you have taken just over the past few weeks?
Everything.
I mean medical.
Yeah, everything.
Cardiovascular,
We took cardiovascular,
Cardiovascular,
hematology,
hematology,
oncology,
forensic medicine,
forensic
Yeah.
medicine, okay,
family medicine.
pulmonary, but not GI yet.
no.
GI 3, 5,
Next
6
semester.
is next,
Next semester.
like January.
Yeah.
Okay.
Before January. By January.
I'm confused now with this.
No, after January.
After January,
Yeah,
okay.
yeah.
But now for the MSK, what have you taken? Like anatomy-wise, pharmacology, physiology, what have you taken?
Osteoporosis.
Can someone just talk? Because I need to concentrate. Go ahead. You, yes.
Yeah, we took osteoporosis and the pharmacology, everything about it.
Excellent. So pharmacology, if I ask about DMARD, you know DMARD?
Yes.
Okay, that's good. Do you know the biologics, for example?
Yes.
If I say anti-tumor factor alpha, you know that? That's great. Do you know, for example, the anatomy of the joints and bone, the muscles, etc.? So you know the anatomy, you know some physiology, and you know the pharmacology,
Also pathology.
and pathology, and histology.
Part of it.
Part of it. Like if I say what do you see, for example, in muscle biopsy in patient with myositis? You know? Okay. But not specific to that disease, general, okay. Okay, so, do you have clicker here or I have to put my clicker? Because I don't go back and forth. Hey, let someone, I have actually a procedure after like, maybe it's around 9:30, so I have to make it faster a bit. By the way, this USB is not working. Do you have another site? Is it there? This is the PC. Okay, gotcha. Right, okay, let's start. So, we'll be presenting today about arthritis and osteomyelitis. They're two different topics. Let's agree with that. Arthritis and osteomyelitis. Can you please concentrate? And I don't like anyone to just get busy with their laptops or with your phones. You can write your notes, handouts will be given to you at the end. But concentrate because I'm going to ask you questions. This is a lecture, but it will be a tutorial also. So, what do you know about arthritis? What is arthritis?
Inflammation of the joint.
I'm just asking someone, so that's fine, later on you can ask me. Go ahead.
It's the inflammation of the joint in different.
Itis is inflammation, correct? You agree about that?
Yes.
Okay, that's great. We agree that arthritis is joint inflammation. So what are the symptoms and signs of inflammation? You know, from pathology, what are the three?
Pain, swelling,
Pain, swelling,
and redness.
and redness in general, and sometimes loss of function, okay? So pain, redness, swelling, and you can lose the function of that organ, okay? Perfect. Okay, that's the joint. Let's move to the osteomyelitis.
Osteomyelitis is the inflammation of the bone or the bone marrow.
So inflammation of the bone and the bone marrow. Excellent. So the osteum and liver. That's fine. Can you name for me two conditions that can cause arthritis? Any condition? Gout. Septic arthritis. Rheumatoid arthritis. Osteoarthritis. Not osteomyelitis. Osteoarthritis. Can osteomyelitis cause arthritis? Yes, it's really go deep and invade the joint Everything else will cause arthritis.
Hyperthyroidism.
Huh?
Hyperthyroidism.
Hyperthyroidism. Hyperthyroidism doesn't cause arthritis. It causes arthralgia. You have to differentiate between pain and discomfort compared to like real inflammation. Okay? I sometimes get really fatigue and just getting pain and aches in the joint. This is arthralgia. Because arthritis, it has to be like inflammation, swelling, there's a fusion, there's a fluid usually. There's a minimal fusion, you might not be able to see it, but it is there. Okay. So let's move on. So these are the objectives. I'll go through them quickly. So we are going to describe the epidemiologically. I'm not really a big fan of talking about epidemiology. Like country in the States or the UK or Saudi Arabia, it's different. And I don't think it would be fair to ask a question, tell me about incidence or prevalence of rheumatoid in Saudi Arabia. But what you need to know, which one is it more common in male or female, and what age you might see this condition, okay? Is it increasing or decreasing? Most of the conditions actually increasing, okay? So we are going to discuss about osteoarthritis, rheumatoid arthritis, spondyloarthritis. This is by each one of them, by the way, take a lecture, believe it or not. It will need 1 hour, okay? But we're going to give like 10-15 minutes for each, okay? And there's another one called pseudogout. You know about gout and pseudogout. Then the osteomyelitis is another topic that, again, take usually 30 minutes to 1 hour presentation, but we'll make it to the point in around like 15-20 minutes, okay? So, what's arthritis? And you already stated, it is very clear that arthritis is inflammation, swelling, redness of a joint, okay? And you can tell from the image here that there is inflammation here, redness, swelling, and redness. Who would like to classify arthritis for me? Anyone? You want to classify arthritis? Yes, you are the one who's smiling. Just give it a guess. Try. I'll accept anything you say. Classify it for me. You want to help? Go ahead. Okay, how we classify arthritis? Anyone?
Primary and secondary.
Primary and secondary, I'll accept it. That's fine. Sorry?
Axial and peripheral.
Axial and peripheral, that's fine, that's good classification.
Positive, negative.
Inflammatory and non-inflammatory. So you start trying to think smart. So always in medicine, try to make your life easier by putting classifications and categorizations. Okay? For me, I think it would be easier to classify it into monoarthritis, either one joint, or poly or oligoarthritis, which is usually 2 to 4, and poly, more than 4. Now, the exercise is, I want to tell me, you, monoarthritis, give me an example of monoarthritis. Typically. What's the condition that will cause only rest? Carpal tunnel, no, it's not, by the way, not the joint. Septic, yes, can be septic, but usually septic will be in the ankle or the hip or the knee, that's fine. Septic is a good example. Septic arthritis is a good example of monoarthritis. Usually it is single. Gout is a good, because we know that the big toe usually is affected by the gout arthritis, and it's a good example of monoarthritis. One. But let's move to the next one. Oligo, which is like 2 to 4. Give me a condition that will cause 2 to 4 joints. Rheumatoid started as oligo, but later on we'll move to poly, okay? Osteoarthritis. Excellent. So now we know at least each one will cause what. But I think we covered this, we covered that. And this is the classification. The slides with you, you don't need to write anything, just bear with me, please. Now, who would like to read the case for me? Do you have another mic?
No.
Because I want your contribution, I want your help. Because by the end of the day, I will get sore throat, so I'll let you participate in the discussion. Hey, okay. Okay, can you hear me now?
Yes.
Excellent. Go ahead, Andrew.
Yeah. Case 1, a 60 female present with a pain in the joint after of her hand, mainly the thumbs, pain worse after grading, slight swelling present, gardening, pain eased by paracetamol.
So relief.
Relief.
You know the Socrates, by the way?
Yeah.
Socrates, okay.
Hypertension,
She's an
amyloidosis,
amlodipine, is a drug for hypertension, calcium channel.
retired secretary,
Liver smoke.
never
No.
smoked.
So, where's the pain?
Thumb.
Thumbs and
Hands, mainly thumbs. So, this is mono or oligo or poly?
mono.
No, oligo. Okay.
Hands and thumbs.
Hands, okay, but mainly in the thumbs. Thumbs, okay, the joints, so 2. Yeah. Let's continue. Continue, please. Read it.
On examination, not grossly deformed, a squaring of the thumb joint, tender over PIPs and DIPs, do hair buttons and dry turning with slight discomfort.
Okay. You see image. So what's your diagnosis?
Osteoarthritis.
Osteoarthritis. Can this be rheumatoid arthritis?
No.
Why?
Because the DIPs
Usually the VIB and DIPs,
are in
and, okay,
And also,
and these are cardiopharyngeal usually rheumatoid, okay,
also
Ulnar
thumbs,
deviation.
thumbs.
and the rest, and the swelling of the thumb base. Excellent. So now you start to differentiate between the two. And let's go back. If you see that, she's 60-year-old. So the age is very important. Age, female. Okay? Age. Usually rheumatoid arthritis will look later on what's the age and the face. Okay, so the osteoarthritis, can someone simplify if I don't have time to read and I want 3 or 4 words about osteoarthritis and I don't understand anything in medicine? Simple words. What's it?
Degeneration.
So usually it is, we always describe it like if you have your grandmom or grandfather and they start to learn, oh, I have my knee joint. The doctor told me that you have a problem with friction and the cartilage is already start to disappear. So who are at risk of osteoarthritis? Elderly. So it is aging process because you are losing obese patient, excellent. Trauma. And joints, so specific. So what are the joints that usually selected? Neck,
Weight
knee,
bearing.
small joints with hands like our patient, cervical spines. And keep in mind, any other joint can be affected. But usually, we see in either hands
Or knees.
and knees and hips. Okay, osteoarthritis. What happened to the patient usually? What they will do? If they get the pain, they'll get painkiller. Okay? Usually, if there is a swelling, if there is an inflammation, really, unless it is severe or get infected or superimposed with another like gout or sore gout. So there will be limitation and reduced quality of life. So now you have to go back to your anatomy. And remember, joint. We need to have really big joint to describe the anatomy about it, okay? As you remember that this is actually, it's divided into 2 parts. I don't see mine. You can differentiate between the one on the left and one on the right. Okay?
Yes.
And you can see the cartilage start to be affected and inflamed and start to be atrophic. Okay? And there is inflammation in the bone and forming like small cysts. And so what is it? Is it just because of the aging process? No, it's more complex than that. So there is an inflammation, there is triggers, interleukins, that trigger some sort of inflammation that will cause the cartilage to start to be eaten and disappear. And remember that you cannot really replace cartilage unless you stop this inflammatory process, and this is really not really the case. You cannot sometimes stop it because the inflammation is ongoing. So there is interleukin IL-1, okay, that will be actually pro-inflammatory cytokines will be capable to induce chondrocyte and synovial cells to synthesize the MLPs, which is going to affect the cartilage cells, okay? So remember, there is an inflammation because of interleukins that will be affecting the cartilage and joint. You correctly stated risk factors, and mainly obesity and trauma, and aging, of course. So, loss of function, the patient will start. Is it reversible? Does it go back to normal?
No.
Unfortunately not. But you can slow the progression, okay? The cartilage once start to really get inflamed and disappear from life. The joint will be difficult to be replaced. So now we have the BIPs and PIPs. BIPs, usually when you examine the hand, you will find like a bony projections or bulges. You call it what? Hypertonic one. And the other one is the foot channel, okay, in the hand. And very classical, if you go like and you see the elderly, sometimes they do have it, but they don't have symptoms. Don't think that anyone who has these things of theirs having a lot of pain. Sometimes very mild. And due to loss of function, especially after like the age of 70s and 80s, like mechanic hands, and they are doing a lot of manual work. And as we have seen in our patient, the image there, square thumb, okay? If you do any blood test, you think it will be normal or abnormal? Usually not. So if you do CGC, if there is markers, if there is an effusion in the joint, and you aspirate from the joint, there will be no significant inflammation or like mycobacteria or any like pus cells. There are images that we can do for the patient. What is the simplest technique to do an image?
X-ray.
X-ray. Simple X-ray. What you will find?
Using
Loss of the joint space. Thank you. That's really great.
Subchondral cyst.
Huh? So the joint space, instead it was like, say, 5 millimeter, it will be like 1 millimeter or 2 millimeter. So you lose it because the cartilage was there, you don't see it anymore, it disappears. What else? Subchondral sclerosis. So there will be, the subchondral space, it will be whitish, like there is a line, you see it in the X-ray. What else? Under that,
osteophytes.
there will be osteophytes and there is cyst, subchondral cysts. Excellent. Okay, let's look at the images. So as you mentioned, these are correct. And these are the images you can see. This is the normal. I think you appreciate which one is normal, which one is abnormal.
Yes.
Clear?
Yes.
Why the one on the left side is abnormal?
Because of the joint narrow.
Narrow space, what else?
Osteophytes.
You might see this one, it should be more prominent in fact. This one should be like more than this. Should be whitish here, okay? And sometimes what do you see here?
Subchondral cyst.
And what do you see sometimes here outside?
Osteophytes.
Osteophytes, like projections. Projections, okay? Excellent. Any questions so far? Clear?
Yes.
What is it? Risk factor, presentation, physical examination, x-rays, and labs. Okay? Now, let's move on. So now you diagnose the patient. How to manage? So it is irreversible. خلاص, what happened? Once the cat jumped from the bag, it's خلاص, out. Then you have to bring it back, but sometimes it's really difficult. Okay? So what you will do?
Pain management.
Pain management.
Slow progression.
So pain management, is it going to help the patient? Of course,
No.
but it's not going to reverse.
So this is,
We
What's
try
the
to
most of
slow
it?
the progression.
How? How you slow the progression of the
Insects.
disease?
Decrease
If I am obese, like my body mass index is 40, you will ask, okay, you have now a big task for you to lose weight. Because there is a lot of pressure on the joint. You can use a cane for the time being. You can do like swimming and exercise that will not affect the joint. But never stop using that joint in a way or another. You have to send him to a specialist, orthopedic, physiotherapist, to train the patient to do the correct exercise. Not to do it by himself at the beginning. So he has to know what are the correct techniques. Believe it or not, sometimes they do exercise and teachers they think this is good and actually they do more harm to them. So we send the patient, please go and see a rheumatologist, orthopedic, physiotherapist. Let them teach you for a visit or two what to do with this joint, what to do with the joint, what are the exercises that you have to do. However, don't stop doing exercise because of pain. Okay, take painkiller. Now, how many painkillers we have? Many. Some of them are simple, like paracetamol. Some of them stronger, like NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen, like Voltaren, like indomethacin. And sometimes we have to go even more, like with the tramadol or morphine, but rarely patient will require. Usually the patient do very well on acetaminophen and on NSAIDs. Okay, let's proceed. I think we have to educate the patient about what's the diagnosis, what is it, and you have to explain it in a simple way. You don't really need to confuse a 78-year-old female about pathophysiology because sometimes told us there is an interleukin coming and do good. No. In a simple way, you draw and explain it and how to preserve this joint. You agree with me? You educate the patient. The diagnosis is this. Improve function. How to improve function? Again, this is why you pay us. It's not your task as an internist or student. You need someone who's specialist in this particular field. Muscle strengthening, why? Because this will help actually the joint and will relieve the pressure on the joint. Avoid unnecessary steps, okay, like jumping, okay, or like twisting the joint. Stick, I think, will be fine, especially, I know the elderly, they don't like it, because they don't feel comfortable to use it. Weight loss, I think the patient is really overweight. As I told you can do it orally, or you can do it topically. If you go to the pharmacy, you'll find what you call deep heat. It's a red tube. It has like, you know the fix?
Yes.
Smells like if you put just small, the one outside will smell it, okay? It's inside, it will penetrate the skin to go to the joint. By the way, it can go to the bloodstream and can go even to the kidney, okay? They are using it a lot. So it's topical. And sometimes the patient really doesn't really feel comfortable. We have to inject the joint with like either hyaluronic acid, like a viscous material, or sometimes steroid. But this is temporary. This will not reverse the damage, okay? So we give it for like a patient who cannot really tolerate the NSAIDs because, for example, they have gastric ulcers, they can't tolerate it, paracetamol doesn't work for them, we go and inject the joint. And this has to be done not by you, not by me, not by a specialist. Because you want to reduce infection and you give the patient septic arthritis. So it has to be a sterile, aseptic technique, and should be sterile, aseptic technique, by really specialists. Now surgery. How many of you know a person who had a knee replacement? 3, 4, 5, 6. Yeah, for example, 100, probably 5% or 10% more, I'm sure, but you don't know about that. Okay, it's really common procedure. I have 2 of my sisters, they have it already. Okay, one of my colleagues yesterday, he was mentioning that his sister was going to have it. Unfortunately, it's really common, especially with really overweight and you know the conditions now. Unfortunately, the joint has to be done by orthopedic, by really excellent doctors because it has to, and they need physiotherapy after that. It's not just, remember, it's in the bone itself. And it will cause some pain, some discomfort. I remember my sister, when she has it, she's in the hospital for almost a week and another week for physiotherapy. But now she's doing very well, actually. With this joint, she's happy, actually. She can walk, she can climb stairs, and again, she's preparing, I think, the second knee now for replacement. Okay. Any questions? Great.
Articular strip injection, like
how often? You can do it frequently, like every 3 to 6 months. If this is helping the patient, the steroid, that's a good sign. I can give you more. But don't overuse it. Remember the steroid and anti-inflammatory, but sometimes really cause damage to the joint. Just it is relieving the pain, reducing the inflammation. What's going to be my time monitor here? Okay, 30 minutes of it. Right. It's really very straightforward for you. I think this is the take-home message. Okay, very important is not to lose the function. Train the patient, walk, do exercise, but don't do it by yourself. Always ask for experts. Okay, case number 2. Let's go to the male sides. Please.
34 female presents 3 months history of
You
pain.
know this lecture is about all females. I don't know why, but most of my kids are females. For the last one, I hope to be a male.
History of pain of the small joints in her hand. Pain worse first thing in the morning, associated with stiffness. Takes around 1 hour for the stiffness to go away. Feels more tired than usual. Notices swollen hands.
Okay. Swollen hands. Hands, not just a thumb or a wrist. Okay. What is here? This is very important actually. I think that you remember. Stiffness. And early morning. And look at the age. Age.
She's
The
young.
patient was 60 plus. This is 30 plus. So both are females. By the way, osteoarthritis more in females, but also we see sometimes in obese males. What do you think the diagnosis?
Rheumatoid arthritis.
Like, continue please.
An examination. Slightly swollen over the MCP and PIP joints of both hands. Tender. No obvious deformity.
Okay. And do you agree with me that there is swelling here?
Yes.
And swelling there, but look at this one. What do you think about it?
Distal is not
The
affected.
PIP is really not scaled, obviously. So PIP, proximal, okay, and MCPs. Okay. Differential diagnosis.
Rheumatoid.
Girls, we said more arthritis usually, so this is polyps out, no? Rheumatoid,
Seronegative.
seronegative, okay. Number 1 rheumatoid, I think I agree with you. Rheumatoid. Could be osteo. Can be, but I mean the age is against that. Again, septic usually mono, usually one joint. Okay.
Maybe autoimmune, arthritis.
Autoimmune. Lupus can be systemic lupus erythematosus. Yeah, and lupus can do anything. So I think I agree with you. Rheumatoid number 1, number 2, number 3. Then osteo. I put other differential less likely, but keep in mind. So in your exam, always be smart and put the most likely diagnosis number 1. Don't think, well, I will tell the examiner that I know body manager rheumatic, so I put it number 1. No, this is not good. So mention rheumatoid is most likely to arthritis. You agree with me?
Yes.
Thank you. Right. So, in comparison to that, osteoarthritis, rheumatoid arthritis is a chronic, but it is systemic. It affects multiple organs, not like osteo. Okay? Inflammatory disorders, immunology primarily involve the joints. Okay? Prevalence is 1%. I don't like you to remember any of these numbers except remember it's more in females and usually age between 30 and 50. Not like that one above the age of 50 or 60. Remember the consequence of rheumatoid arthritis: mortality, morbidity, reduced quality of life, and disability. If you want to choose one of them, which one you will choose? Rheumatoid or osteo? Osteo. It's affecting one joint and can replace it and can. But this one really is very because really a lot of really impact, negative impact on the patient. Okay? Because it is systemic, just affecting many joints and can involve other organs. Okay, so it is an autoimmune disease, you agree with me?
Yes.
Okay, there is an what are the other autoimmune diseases in your mind?
Systemic lupus.
Lupus,
Jorgen syndrome.
Sjogren's syndrome? Huh? Sarcoidosis? Autoimmune sarcoidosis? I'm not sure, it's granulomatous disease, but I'm not sure what it is. Lupus, they mentioned it, systemic sclerosis, okay? Scleroderma, excellent. What else? In GI, I want something from GI, please.
IBD.
IBD, thank you. And what is the only condition that you know the trigger of it?
Osteoarthritis.
No, all the autoimmune diseases, you don't know the trigger. And you cannot stop it. But there's condition one, autoimmune.
Rheumatoid.
HLA-B27
disease.
HLA-B27.
No, you can't solve it. Yes, you can't. You can't.
Rheumatoid Factor.
No.
Crohn's.
Crohn's, you can't. It's autoimmune. What's the etiology? Tell the patient to avoid something and still will continue.
IgM, agglutination.
GI. We are very smart in GI. We know what's the etiology.
IBD.
Shigella.
Celiac. Celiac disease is the only autoimmune disease that we know the trigger. Which is what?
Gluten.
Gluten. Okay? You think it's allergy, it's not allergic. It's an autoimmune disease. Okay? I'm going to present it later on in my GI lecture, inshallah. We'll see you. And I'll be more aggressive than rheumatology. Okay? I promise you. So you need, and always for autoimmune disease, you need genetic background. So you ask the patient, do you have a family member? They will tell you, yes, I do have like my mother or my sister or my cousin or like that. Usually there is autoimmune background. So the only thing that you should remember is this image. So the joints that will be affected, okay? So metacarbopharyngeal and proximal, endopharyngeal, wrist, thumb, knees, and other joints, okay? And remember there is usually morning stiffness. They get stiff in the morning. Usually lasts more than 1 hour. Swelling in more than 3 joints. There are criteria, okay, for diagnosing rheumatoid arthritis. Okay? I'll skip this. I can read it later on. But remember, the joints are usually swollen and warm, but not red. It might be actually firm, okay? But not really swollen like septic arthritis. No. Morning stiffness is really one of the unique features in rheumatoid arthritis. They get to be stiff in the morning. They can't even move the joints. Okay, no, they can't try it. On both sides, remember, you cannot get rheumatoid on the right side only, and the left side is normal. So usually it is polyarticular, symmetrical. Symmetrical. And the duration usually for the stiffness is more than 60 minutes. I think we have seen this image before, and you agree with me that there is swelling in the proximal interpharyngeal and metacarbopharyngeal. What do you see now? This is early, this is advanced. Deformity, start to deformity. But the good thing in this condition, we can control the disease. There are a lot of medications and many different coming pattern. We can control and solve the condition. You know, this is again very advanced rheumatoid arthritis. See swollen, you can see Z deformity of the thumb, okay, swan necks, swan neck they call it, swan neck deformity. Okay, there are many images, and can't affect the good hands, can't affect the feet. This is the swan neck, remember, like a swan. They call it peritoneal deformity. Remember that one for osteo is the butcher nose. So remember the B and B is different. Okay? And Z deformity of that. No. So we know that rheumatoid factor is usually positive, and there is sometimes the subcutaneous pressure points and internal organs can be affected. It's not only limited to joints. We see sometimes patients having a lung involvement or other organ involvement because this is a systemic disease. What are the conditions that cause systemic disease other than rheumatoid? Many, sarcoidosis, correct. What else? Lupus, IBD, celiac, multi, okay? So rheumatoid is one of them. multi-system disease. Okay, so the extra-articular, this is a different story. You have to ask the patient when they come to you with the joint pain, you have a checklist, review of systems, they call it. You ask about allergies, okay? So pleuritis or pleural effusion, and the patient will not tell you, well, doctor, I have pleural effusion. He doesn't know. He'll tell you, well, I have shortness of breath, I have cough, I have pain, okay? But you have to think smart. So I know rheumatoid can affect the pleural space. Cardiac manifestations, again, it's a long list. You didn't need to write these ones, by the way, handouts will be in the desktop, so you can take it as well. Pericarditis, pulmonary amyloidosis. Remember, amyloidosis, this is what's called secondary amyloidosis. Any chronic inflammation, even IBD, it can lead to secondary amyloidosis. So the position of amyloid. Kidney can be affected by the disease itself, or it can be by the medication you are using to treat rheumatoid arthritis. Okay? Hematological can be anemia, Ferty syndrome, neutropenia, thrombocytopenia, eye manifestations. There are many, like keratoconjunctivitis, inflammation of the eye, with some dryness, sickle. Scleritis and scleritis can be affected. This even we see them in IBD, because remember IBD is also multi-organ disease. And one important thing is you remember C1, C2 subluxation. Why? If the patient is going for general anesthesia and they would like to intubate the patient. So remember, this is subluxation can affect the patient's spinal cord. So always anesthesia, they know this, and they have to make sure that the joint is really preserved and safe. There are criteria, as I told you. It has been published long time ago. I think before we have been born, of course. But they are still using it. It didn't really change much. Criteria. So basically, they said we need to have something to differentiate between apple and orange. Okay? They want more stiffness, arthritis of 3 or more joints. Hand is very important to be involved. Symmetric. We said this is really one of the most important features of rheumatoid. Nodules, where do you find the nodules? You usually see them here, small like lumps here. Rheumatoid factor and radiological features. So you need to have 4 to think this is most likely rheumatoid arthritis. Again, rheumatoid factor, it is an antibodies that we, now it is, I'm not saying it's losing interest to do it because you have more specific antibody, what is it?
ACP.
CCP, anti-CCP, but we are still doing this one. So rheumatoid factor, remember, it is positive in like 50% at the beginning, but later on will be in 85%. So at the beginning will be 50%, but later on will be 85%. And it's not useful for diagnosis or follow-up. Because, why is that? Because many conditions will be false positive, will cause high rheumatoid factor. So we cannot really judge on it. Okay, the criteria that was put in 1987, they don't have the CCP at that time. Okay. Useful for prognosis because you know when we do it and we find it positive, most likely those patients will progress. Okay, to more severe form and think really ahead of time that I need to be more aggressive in such patients. And this is the one that we are using nowadays, is the anti-CCP, more specific, and sensitivity more or less the same, but the specific is very important. It's more specific. Rheumatoid arthritis and related to the osteomyelitis. Right. Now, I think you didn't need to remember this list. That can be positive for rheumatoid factor, but keep in mind it is not specific. Images, what do you see? Can someone tell me what do you see? Anyway, is it normal or abnormal? Abnormal. You see there is a deformity already. Is it early or advanced? Advanced. Simply advanced. You see the even the joint space has been lost, and there is erosions here in the joint space. Okay. And what do you see here? Again?
Osteopenia.
Okay, good. What you see? Osteopenia, joint space narrowing, avoidance, and malalignment. How to treat rheumatoid? Again, we'll go back to the